Okay, so let's go on and do a bit of an anatomy review of the heart. We'll discuss some topics in health history, um, physical assessments for cardiac issues, and diagnostic evaluation. Okay, so let's do a quick flow through the heart, and we're going to start on the venous side. So blood is going to come back from the inferior vena cava, so the lower part of your body, the superior vena cava, the upper part of your body, and flow into the right atrium. Okay, the right atrium is going to allow blood to flow into the right ventricle through the tricuspid valve. So that's a leaflet valve. Okay. The right ventricle can then pump the blood into the pulmonary artery through the pulmonic valve, and that's a cusp type valve. Okay. And the pulmonary artery splits into two, left and right, going to the left and right lung. Okay, where it's going to get into smaller and smaller branches of the pulmonary artery until they become capillaries at the alveolar level to receive oxygen from the alveoli and get rid of the CO2. The blood's going to return to the left side of the heart by the pulmonary veins, which is now oxygenated blood. Okay, and that's why it's in red in this image. And it's going to flow to the left atrium. Okay. After the left atrium, there's the mitral valve. Okay, that has two leaflets to it. It's a leaflet valve. Flows into the left ventricle, which is the powerhouse of the heart, with a very thick muscle for pumping against systolic blood pressure. It's going to flow through the aortic valve, which is a cusp valve with three cusps to it normally, into the aorta, right? And finally, from the aorta, it's going to flow to all the different organs in the body. Now, you can't see the coronary arteries in this image. Their coronary arteries are on the surface of the heart. So they come off the first part of the aorta, and you have a left coronary artery and a right coronary artery. And then they branch off and go to all the different parts of the heart to feed the heart with oxygen and glucose. So remember, the right side of the heart is a low pressure system. It's the venous side, right? So blood is coming back to the right atrium from the veins. So very low pressure, okay? Even the right ventricle is not pumping into the pulmonary artery with high pressures. It's just not needed, okay? Compared to the left side of the heart that has high pressures. So once you get into the left ventricle, well, that left ventricle has to pump at pressures that can exceed the systolic blood pressure, or sorry, the systemic blood pressure to get blood into the aorta. Okay. So what's cardiac output? Well, cardiac output is heart rate times stroke volume. So what's stroke volume? It is how much blood is being pumped out per contraction of the left ventricle. Okay. So for example, if the left ventricle pumps out 50 milliliters of blood and your heart rate is 60 per minute, well, in 1 minute, you're pumping out 3,000 milliliters of blood, or 3 liters of blood. That would be your cardiac output. Okay, so your cardiac output is totally dependent on your heart rate and how much volume that left ventricle is pumping out every time it contracts. So you can imagine someone with congestive heart failure and a really weak left ventricle. They can't generate a lot of force, so the stroke volume will be reduced and the cardiac output will be reduced because they're not pumping much blood out with every contraction. Okay. The concept of preload and afterload. I just think of afterload as the blood pressure that the chamber has to pump out against. So what's the afterload of the left ventricle? Well, it's the blood pressure in the aorta, because that's what it has to push the blood out of the left ventricle at that pressure to get it out of the left ventricle. What's the afterload of the right ventricle? Well, it's the blood pressure in the pulmonary artery, because that's what it has to force blood out of the right ventricle to get into the pulmonary artery. Okay. What's preload? The preload is really the pressure and the volume during relaxation of a ventricle. And what's happening during relaxation is blood is returning to the ventricle, say the right ventricle, as it's relaxing, and blood is filling the right ventricle, and it's stretching it, and it's loading it for the next contraction. So, for example, if you have no blood coming back from the inferior or superior vena cava, and so there's no blood flowing into your right ventricle, well, your preload is 0. Okay, so the preload is the pressure in the volume that's stretching the ventricle, getting it ready for the next contraction. Okay, and we care about that because there's some drugs that can lower the preload. There's some drugs such as nitroglycerin that can vasodilate the veins and really reduce the blood that's returning to the right ventricle and reducing the preload. Okay. So I think of the preload of a ventricle as the filling of the ventricle with blood, stretching the fibers of the myocardium, getting it ready for the next contraction. And if the blood doesn't fill the chamber, well, there's no preload. It didn't fill it properly. Okay. And the afterload is how much blood pressure do I have to pump against to get my blood out of the ventricle. Okay. There's a note here at the bottom on the slide in terms of women developing coronary artery disease typically 10 years later than men. And that's true. Women develop heart disease and they catch up with men about 10 years later. And the reason for that is estrogen is very protective for the development of cardiovascular disease. So after menopause, where women no longer have any estrogen in their system, coronary artery disease becomes much more prevalent in women. Okay, and they actually catch up to men in terms of developing coronary artery disease. Okay, so let's do some questions at the back of chapter 27. Number 1, a nurse is orientating a newly licensed nurse on the care of a client who is to have a line placed for hemodynamic monitoring. Which of the following statements by the newly licensed nurse indicates understanding? So it sounds like they're having an invasive line put in because it's for hemodynamic monitoring. So if it's through a vein, through a central vein, such as the internal jugular or say a femoral vein, we're going to monitor the pressures on the right side of the heart. If it's through an artery, so an arterial line, we're going to monitor the pressures on the arterial side of the heart, okay? Much higher pressures. So let's have a look here. Which of the following statements by the newly licensed nurse indicates understanding? Air should be instilled into the monitoring system prior to the procedure. Boy, I really hope not, because that means air is traveling to your heart, which will be an air embolism. B, the client should be positioned on the left side during the procedure. That's not true when you're placing a central line. In fact, the patient's typically supine, so flat, or in Trendelenburg, where the head's down a bit. Okay. The transducer should be level with the second intercostal space after the line is placed. The transducer. So the transducer is the machine that's monitoring the pressure. That doesn't need to be at the second intercostal space. Typically, the transducer is put at around the fourth intercostal space, which is supposed to correlate with the right atrium. Okay. A chest X-ray is needed to verify placement after the procedure. Okay, that's going to be the answer, right? So whenever a central line is put in, a chest X-ray is done to see exactly where the placement of the line was put. Because these lines have little markers on them. And when we X-ray, we do a chest X-ray, we can see exactly where the line got to. Okay, so that's the answer. Okay, I find with a lot of these questions, just look for the answer that makes sense. Do I need to do a chest X-ray after putting in a central line? Yes. Okay. Because a lot of the questions or answers sometimes don't make any sense. A nurse is assessing a client who is undergoing hemodynamic monitoring. The client has a CVP of 7 and a pulmonary wedge pressure of 17. Which of the following findings should the nurse expect? Okay, so if you go back to the chapter and look at the values of what we expect in terms of pressures on the right side of the heart, that will tell you whether they're high, low, or normal. Okay, if someone's extremely dehydrated, the right-sided pressures in the veins and the ventricle and the right ventricle and the pulmonary artery, they're going to be low. If they're high, well, that usually means that the person is well hydrated and something else may be going on. So let's look at the first answer. Poor skin trigger. No, these values are on the high side. So poor skin trigger wouldn't cause this. Bilateral crackles in the lungs. Sure. So if you have congestive heart failure from left ventricular failure, it's going to back up the fluid into your lungs. It's going to cause an elevated pulmonary wedge pressure. And it's also going to back up fluid into the right ventricle and right atrium, causing an elevated central venous pressure. Okay, so B is going to be right. Jugular venous distension. Well, that's just backup of blood in the veins. That one's going to be right. Dry mucous membranes. No, that's trying to indicate dehydration. No, these pressures are on the high side. D or E, hepatomegaly. Sure. If you have elevated pressures on the venous side, it's going to back up to the liver, causing hepatomegaly. So the answers are B, C, and E. Number 3. A nurse is teaching a client who is scheduled for a coronary angiogram. Which of the following statements should the nurse include? You should have nothing to eat or drink for 4 hours prior to the procedure. So typically it's 8 hours prior to the procedure. We don't always have that luxury if it's an emergency coronary angiogram, sorry. But if it's a booked angiogram, then preferably it's 8 hours. You will be given general anesthesia during the procedure. No, that's not true. Often the patients are just lightly sedated, or they're awake for the procedure after having had some local anesthetic, so they don't need a general anesthetic. C, you should not have this procedure done if you're allergic to eggs. We often ask if they have an allergy to iodine or shellfish because there's contrast media being used, but not allergies to eggs. Okay. In fact, a lot of the newer dyes, the iodine and shellfish allergies are starting to disappear. Okay, we still ask iodine and shellfish allergies, but the newer dyes and contrast media It's not as big of a deal anymore. D, you will need to keep your affected leg straight following the procedure. That's true. Okay, so after having a coronary angiogram, assuming you had one through the femoral artery, you need to rest in a supine position, okay, to stop any formation of bleeding or hematoma at the insertion site. So that's true. Okay, number 4. Nurse at a provider's office is reviewing the laboratory test results for a group of clients. The nurse should identify that which of the following results indicates the client is at risk for heart disease. Total cholesterol, 245. Yep, that's on the high side. So high normal is 200. So that's a risk factor. An HDL of 90. No, that's a good cholesterol. So the higher the better. Above 45 in males or 55 in females is good. So that's just fine. LDL of 140. So 130 is the cutoff usually. So that's going to be a risk factor, right? Because of an elevated, quote, bad cholesterol, which is LDL. Triglycerides of 125. No, that's still in the normal range, so that would be considered fine. And a troponin of 0.02. No, indicates it is at risk for heart disease. No, that's a bit of an unfair question because they're actually asking you values of troponin I. And different hospitals have different values, so I'm not sure why they're asking that. But no, that's within the reference range. So the answer is A and C. Number 5. A nurse is planning care for a client who has a PICC line, peripherally inserted central catheter. So it's a long line that we insert peripherally, and then we feather it up into the central circulation. Which of the following interventions should the nurse include? Okay, A, use a 10 ml syringe to flush the PICC line. That would be true. Okay, yeah. You wouldn't want to use a big syringe that can generate huge pressures that could blow the PICC line. So that would be true. Apply gentle force if resistance is met during injection. No, not usually. You don't try and overcome resistance by just pressing harder. There's usually a reason why there's resistance. So either the PICC line is blocked, or there's a clot in it, or it's kinked. So there's usually something wrong with it. Okay. C. Cleanse ports with alcohol for 15 seconds prior to use. Yes, that's a good idea, right? So you really want to reduce the chance of injecting any bacteria into the PICC line, so C would be appropriate. Maintain a transparent dressing over the insertion site. Yes, that's a good idea. We get to visualize the insertion site, right, for signs of infection at the insertion. E, flush with 10 mL of heparin before and after medication use. No, I don't think so. PICC lines are usually flushed with normal saline before and after the medications are given. Sometimes if a PICC line is not going to be used for a prolonged period of time, heparin can be instilled in the PICC line just to prevent any clotting, but typically it's normal saline that's used. Okay, so let's review the electricity of the heart. Okay, so the electricity of the heart is critical so that the heart will then take that electricity and turn it into a contraction by stimulating the myocardium, right? So we have automated pacemakers in our heart that are continually sending off a signal to the heart that's going to turn into a contraction of different parts of the heart. Okay, so let's talk about the normal physiology of the electricity of the heart. So that starts at the sinoatrial node. And when I call it a pacemaker, it's a natural pacemaker. It's influenced by the autonomic nervous system, where the sympathetic branch can increase the signal from the SA node and make the heart go faster, or with the parasympathetic branch, it can send a signal to the SA node to slow down the heart rate. Okay, so the SA node is an automated pacemaker. It continually depolarizes and repolarizes, and it sends out an electrical signal to the atrium. Okay, so let's see where the electricity goes. So first it starts at the SA node, and the electricity goes over both atria, right, through nerve fibers, and that's going to result in contraction of the atria. Okay, where does the electricity go next? So SA node, then over a whole bunch of nerve fibers in both atriums, and it's going to go to the AV node, the atrioventricular node. Okay, so that's a bundle of nerves in the AV node that's getting the electricity. And the AV node is the only electrical connection between the atria and the ventricles. Okay, there's no other normal way for electricity to get through to the ventricles except for the AV node. Once the electricity is in the AV node, it can send the electricity on downwards to a large bundle of nerves called the bundle of His. Okay, the bundle of His is going to take the electricity and it's going to conduct it into the ventricles. It's going to branch into two separate branches, a right branch for the right ventricle, a left branch for the left ventricle, and then the nerves are going to get smaller and smaller, called Purkinje fibers, and they will cover the entire left and right ventricles with little nerves. And then finally those nerves attach to the myocardium, and they can depolarize the myocardium. Okay, so really understand the normal electrical pathway in the heart. SA node, and then over the atrium, AV node, and then down the bundle of His, and then the electricity branches into right and left bundles. Purkinje fibers are the tiny fibers in the myocardium. They're still nerve fibers though. And then finally, the myocardium itself, the muscle itself. Okay, and this is all about causing contractions of the myocardium in different sites, right? So whether we're talking about the atrium, the atria contracting first, and then the ventricles contract to produce a systolic contraction.